a new drug update. Great to be back in person and back on Zoom, which I'm pretty comfortable with now. I'm going to go through a lot of new drugs today and go ahead and, oh, lost the screen though. Okay. I'm going to go through a whole bunch of new drugs. Okay, so no disclosures. I am going to talk about quite a few drugs that are not FDA approved though. And so as a requirement, ACPE, letting you know, I will let you know when I'm talking about a product that is not FDA approved. I'll also have that designation on the screen with the box not FDA approved. Some of the products have emergency use authorizations. Others are going to be drugs that are under FDA review right now. So going over a couple. Okay. A couple of those towards the end. Okay. And now it's not advancing here. There we go. Thanks for your patience when we figured all these things out again after a little break from live action. So the FDA approvals in 2021, there were 50 new drug approvals. So these are new molecular entities beyond just all the new dosage forms and all the expanded indications. This has been pretty typical of the last quite a few years. So really just their typical average pace these days. Notably, 26 of these were orphan drugs, which is a huge number, and that number seems to be growing every year, which is great news for folks who have rare diseases, but aren't drugs that the majority of us are going to see in practice. A lot of them were fast track or breakthrough designation. Just a reminder that breakthrough designation just means that there's hints when it's in development that there might be some benefits. Doesn't necessarily mean it's a breakthrough drug in the sense that we often would think of a breakthrough drug. But quite a few, 34 of them had priority review, so they did get the rapid review. So this year, I think more than any year in the past, I really struggled with which drugs to focus on today. So I'm going to go over a lot of drugs, but some of them I'm only going to have maybe one slide, and really just it's a heads up. Hey, here's this drug. There's a bunch of tables at the end. I'm going to talk about some of those drugs, but not in a lot of detail because honestly, they are not drugs that the majority of us are ever going to see. And so I'm trying to focus hopefully on the ones maybe that more of us will see or get questions about. Gonna launch with honestly some drugs that aren't FDA approved, but are the ones that I'm going to pause for a second. Do I need to be doing the Zoom part? No. So if people are waiting to be admitted, someone else is monitoring. Great. Okay. Thank you. Just wanted to double check. So there are a bunch of products that are out there being used right now. Obviously, most of you are probably really familiar with these products being used for COVID right now, but I just wanted to talk a little bit about them because this is an area that is evolving rapidly, even with all of these agents. So the nirmatrelvir is a SARS-CoV-2 3CL protease inhibitor. So it is an antiviral specific. It's used with ritonavir, which you all know is an HIV protease inhibitor, but they're using it for that 3A4 inhibitory effect. This is a treatment agent and probably is our preferred treatment agent right now for patients with mild to moderate disease who have a lot of risk factors for progression to severe. Pretty easy to use, comes in a blister pack. 2 of the 150 milligram tablets plus a ritonavir tablet. They take those together. Yep, it works. Thank you. And so adjustment in dose, if someone does have some moderate renal impairment, don't use it if they have severe renal or hepatic impairment. Does have some possible hypersensitivity reactions, so just be aware of that, monitor and discontinue if someone has a reaction. 3A4 drug interactions, obviously we're using ritonavir, so there are going to be the potential interactions there, and then hepatotoxicity is something that they're at least looking at. Efficacy-wise, this is the agent that showed the best results so far amongst antivirals that have been tested. So reduced the chance of progressing to requiring hospitalization or death by about 6 percentage points as an absolute difference, so an 89% reduction in a relative risk. So pretty good data there. And the main side effects are just an altered taste and diarrhea. And then the reminder to report serious adverse events and medication errors with all of these agents. So part of the emergency use authorization process requires documentation of any serious adverse events as well as medication errors. So just that reminder with all of these. And the link at the bottom of the slide is to the FDA's emergency use authorization page for the COVID drugs. And so from this page, you can get all of the latest. So as they are making changes to these emergency use authorizations, just a reminder that that's up there, and those changes get posted real time. So you can find the latest changes there. The other antiviral that's being used then is molnupiravir. This is has not demonstrated the same level of efficacy. So it had about a 3 percentage point absolute difference instead of a 6, so not quite as effective. There's also some additional cautions there in terms of pregnancy and use in children based on some animal data. So until we have more information, right now we want to avoid it in those populations whenever possible. And contraception use is required while on it and for 4 days after. Also, if someone is breastfeeding, they should pump and dump while they're on it and for 4 days after. With all of these, obviously, you need to be providing that fact sheet for the patient or the caregiver with any of these emergency use authorization, because these are still technically investigational drugs. They're being given under investigational protocol. But in this one, it's particularly critical because of that pregnancy information that you document that you did provide that information. Mislabeled this slide, I apologize. These are not at all antivirals, but just some other additional COVID therapeutics. So just a reminder that tocilizumab and baricitinib are both being used in this population under an emergency use authorization. And so the data on these is kind of all over the place. So some of the studies showed that there was some promising activity and it looked like it did help with the inflammation. And so some of that severe COVID response. In others, it was not seen. So the guidelines right now are really just if someone has rapidly progressive disease, the severe inflammation, rapid changes in oxygen requirements, then it's probably worth a try to add this along with their other therapies, particularly dexamethasone and plus or minus remdesivir, which the data also is a little bit conflicting on. But both of those are authorized for use right now under emergency use authorization protocols. So that they're FDA approved drugs, but we're also authorized for this use. And then remdesivir, FDA approved already last year, but it also has additional broader uses under an emergency use authorization. So recognizing that you can use it in pediatric patients as well that were not under 12, that were not authorized under the approval, as well as patients who are not hospitalized. So if you have patients that kind of fit the same requirements as the other antivirals, you could go ahead and use this. The difficulty is it is an IV drug. You have to monitor the patient for an hour afterwards. And we don't have quite as much data really in that use. So it's preferred when those other therapies, and especially the Paxlovid, is not available. Next, I'm going to talk about a couple of the antibody therapies, and this is one of those areas that's rapidly changing. So keeping an eye on this pretty much daily. So bebtelovimab is the newest approved antibody, not approved, authorized antibody. These are all, again, under emergency use authorization. And again, this is for mild to moderate disease, pretty much the same indications as the antivirals. So this would be, if the antivirals aren't appropriate, if the person if they're not available, if you can't get them, but you could get this. If if they, because of drug interactions or pregnancy or other requirements, those aren't good choices, then this would be a good choice. So it is a 1 IV dose, monitor them for an hour after again. Within 7 days of symptom onset, which is a little bit longer than we're seeing with some of the other antivirals, which were primarily studied at the 3 to 5 days. So that might be another option here. So far, bebtelovimab is still authorized for use everywhere. So the Omicron variant, all of the agents I've talked about so far were not studied in populations that had Omicron. So these were mostly in either the original variant or some of them carried over into Delta, but we didn't have data with any of these with the Omicron. So they are looking at just activity levels. And so both of the new antivirals do have activity against the BA.2 variant. Bebtelovimab also appears to have good activity against the BA.2 variant. Sotrovimab does not. And so that's why in this last week we saw them pull back availability of that one. So about 2 weeks ago, they limited it. They said, don't use it in the Northeast where the BA.2 variant had increased in prevalence. This last week, they removed it from pretty much the whole West Coast and a good chunk of the center of the country as well. So that's no longer authorized here for use. And then the other two I've listed there also aren't authorized for use right now because of the activity against that new variant. There's a bunch of antibodies in development as well. There's another one that's submitting for emergency use authorization right now. They've already submitted their data, but they don't have activity against this particular variant. So at this time, even if they got authorized, it wouldn't be available for use, but maybe they would hold off and see if it had activity as variants continue to evolve. And then Evusheld, which is another antibody, and this one is for pre-exposure prophylaxis. So this is a really, it's an exciting product with really good data in terms of reducing the risk of infection, but not as widely available probably as I think a lot of people wished and hoped it would be. So it is for pre-exposure prophylaxis in patients who don't have currently an infection or have been really closely exposed to somebody, are immune compromised or weren't able to be vaccinated. And really the population we're seeing it in use is the patients who are immune compromised. So cancer patients, patients on TNF inhibitors are all populations that are great candidates. Patients on transplant recipients, solid organ transplant recipients on immunosuppressants, any of those. The dose now is 300 milligrams of each component. They're administered separately at the same time, well, in close proximity, and you monitor the patient. This is an increase in dose from what was originally authorized. So if you have folks out there who got the lower dose, the recommendation now is to go ahead and either, if it was within the last 3 months, go ahead and give them another 150 milligram dose, which is what they had received. If it's been more than 3 months, go ahead and just redose them with this new higher dose. So they do need the higher dose because of the Omicron variant. It's just to increase that activity. Okay. And then the vaccines. Not a lot to say about them other than there's been, obviously you're aware of all the new, the third dose, the booster dose, those things. 2 of them are FDA approved for the populations listed above. Recognize that those are just for the initial doses. You can still use the labeled FDA approved product or the emergency use authorization products basically interchangeably to suit the needs of the patient. So whether it's an original dose or their booster dose, that doesn't matter. And then the Janssen is still not available as an approved drug. That is still under the emergency use authorization only. Seeing more and more dosage forms of these. So the vials, we have the purple vial and the gray lid vial and the orange lid vial for the Pfizer products. And those are pretty well labeled for the populations that those are intended for use in. For the Moderna, we had the red cap, and that was great. And now they've introduced a new blue cap, which is a different strength. And this is a booster dose strength. and it's not the same volume as you do with the red cap. And so just throwing that out there, definitely an area that I see a huge potential for medication errors. I think there's going to be some folks who get half of a booster dose if someone doesn't use the right dose for the vial that they're drawing from. So just probably if you do have both of those in your institution or your clinic or pharmacy or wherever you're at, just making sure that you double check for that specific product what the volume for the booster dose is. Because this is the first one that has that change in volume. So I'm going to throw out the first question on Lecture Panda and see how this works. I will let you go ahead and pick the answers. I'm probably not going to try to display right now because I don't want to mess up the displays. Okay. So which of the following agents is FDA approved for the treatment of COVID-19? So is it the baricitinib, the molnupiravir, nirmatrelvir, or remdesivir? Which one of those is? Great. Yep. I'm seeing lots of remdesivirs, so I brought it up. I'll take the I'll take the test with you. So that's good. So yeah, just a reminder, baricitinib is an FDA approved product, but it is only available as an emergency use authorization for the COVID, and the others are emergency use authorizations only, B and C. So now done with COVID for today, on my part anyway. Going to talk about a couple vaccines first and then move into some other products. So in terms of vaccines, these are probably things that you are going to see. So the new pneumococcal vaccines. So there's 2 new conjugate vaccines. So we had the 13 conjugate, now we have the 20 and the 15. So Prevnar 20 and Vaxneuvance is a 15. The new guidelines, ACPE recommendations are on the bottom of the slide there. So the new recommendations are that folks over 65 get either the PCV20, which is the 20 valent, the Prevnar 20, or they get the 15 and then follow that by the Pneumovax. So just to broaden that coverage. So it is still a 2-dose if they're going to use the 15, but it can be just the single one if they're going to use the 20. Really the huge probably change is going to be not so much in that population, but in pediatrics. So both of these products are also trying to get approval in that pediatric market, which is a huge market because it is part of the routine series in infants and young children. And so right now, the 15 has submitted for FDA approval. It's within the FDA. They submitted some extra information, and so the FDA delayed the decision by a couple of months. So we thought we were going to see that really soon, but it might be a couple months away. So we will likely see it approved. The 20, it has the pediatric data. They're pulling everything together, but they haven't submitted yet. So at some point we'll see that as well. And so we probably will see within a year changes in the pediatric recommendations as well for the pneumococcal vaccines. But for now, we definitely do in the population over 65 or in adults with other conditions. 2 other vaccines. The first one here, the tick-borne encephalitis vaccine, is probably just of interest to you if you are either working in a travel environment where you provide travel vaccines for folks, or if you are interested in traveling, if you are going to be going to an area where tick-borne encephalitis is prevalent, which is included in that map at certain areas of Europe and Asia, and are going to be spending a lot of time outside, and are going to be there for quite a period of time. So most travelers do not get this vaccine. It's been available in Europe though for many, many, many years. It's routine vaccination there for folks who do live in these areas, and it is highly effective. So if someone is looking to move to these areas, they could actually start the series here now, instead of in the past, they would wait until they got to the area and then do it. It takes about 6 months to complete the series if you do it even as fast as you can. Most of you won't be seeing that or administering that particular vaccine, but we are going to probably see, at least in the military, some folks starting to use it. New recommendations are likely to come out this year on the exact role of it, but it might be of interest to others who are traveling. And then the hepatitis B vaccine. So we have another hepatitis B vaccine. So we have 4 now. This one in clinical trials was non-inferior to Engerix-B, but there are some hints that maybe it has a little bit more rapid and more robust immunogenicity. So clinically, it looks like it's comparable to the other vaccines, but in some patients, there might be a better response. Some folks who haven't responded to the others. It has 3 surface antigen proteins that are included in it instead of just 1. So most of them just have the S protein, and this has the others. And so that they think that probably is why it seems to promote a response in some folks who didn't respond to the others. It is 3 doses, again, like the other 2. The Heplisav is just 2 doses. So it's just another alternative. Expands the opportunity to get vaccine into a broader category of adults. So next, moving away from vaccines, there's a new antifungal that was approved last June. It's for vaginal candidiasis. And this is for adults or teenagers, girls who have passed age of menarche. It's a new class. So it's a tripterpenoid antifungal. It's fungicidal. It works at the cell wall. And so it's different than fluconazole in its activity. And it does actually retain activity against fluconazole resistant candidiasis. So right now that's primarily going to be its role. It's pretty pricey. So this isn't something you would want to use in everybody. But if you do have a patient that you either know that their organism is resistant to fluconazole, or fluconazole hasn't worked, this might be an alternative for them. They're also studying it in recurrent vaginal infections. So there are some nested studies where they've looked at people who failed therapy with fluconazole and then crossed them over to this. So we will have some more data coming in that area. It's also being looked at in quite a few other systemic fungal infections as well, but we don't have data on that at this time. Contraindications, the biggie is pregnancy. At this time, there's just really limited information. And so more so than that they know it causes problems, it's just that we don't really know. And so the recommendation is definitely to avoid it and confirm pregnancy status prior to using this. And they are gathering information right now, and still will likely see some changes. It'll either be absolutely strongly do not use, or they will have some information in the future that would allow it to be used. But for now, really, they are collecting information on accidental exposures, but we should be doing our best to avoid use. Side effects wise, diarrhea, nausea, and abdominal pain. There are some CYP3A4 drug interactions, and so that is something to be aware of if someone's on a really strong inhibitor. But it is just a one-day course. So they take 300 milligrams separated by 12 hours. So you would take 2 tablets in the morning, 2 tablets 12 hours later. That's the entire course of therapy. If it comes in a blister pack with those doses on it, they can take it with or without food. And right now, that drug interaction is probably not going to be a huge deal for most patients. But when we see use in some of the other indications, it's likely going to become a really big deal. There probably is going to be more drug interactions that we need to be aware of because we're going to be using longer courses of therapy and probably some different doses. Next is complete change in subject here, a new sleep agent. So a new daridorexant. So this is another orexin receptor antagonist. So remember, the orexin receptors are sleep promoting. So we're blocking activity there. We're decreasing that sleep promoting activity or wake promoting activity, and therefore helping with sleep. It's for the treatment of insomnia in adults, both for difficulties with sleep onset and sleep maintenance. And it's in the same class as lemborexant and suvorexant. And really the only difference we're seeing right now with this agent is the shorter half-life. So this has a half-life of about 18 hours. The others have a half-life. Lemborexant, I think, is about 19. Suvorexant's about 15 to 17. So they're quite a bit longer. So this one's down to 8, which is still a decent half-life, though, and something we need to be thinking about when we think of next day effects. In terms of efficacy, so just threw up some results here. Basically, standard tests, standard results. So there were some improvements in the wake time after sleep onset. So people get to sleep, and then how much wake time do they have after they fall asleep? So that's one of the main parameters they look at. And they did see improvement in both the 25 and 50 milligram doses here, about 10 to 20 minutes better than placebo. So not a huge difference, but again, that's standard with all of the sleep agents, really. And then same latency to persistent sleep, so improved by about 30 minutes. So they fell asleep faster, they had less wake time after they were asleep. Pretty standard. We don't have head-to-head with any of the other sleep agents, so it's all placebo-controlled studies. And then self-reported sleep time. So patients, when surveyed about, how long did you sleep, independent of whether they were being monitored, reported an increase of about 45 to 55 minutes. So they were up to 6.5 hours of sleep. So almost an hour. Subjectively, they reported that was, of benefit. It's also pretty in line with all of the other sleep agents. Subjects also reported improved daytime functioning as a result of that improvement in sleep. So again, that's a subjective measure in patients. But we still need to be aware of the next day problems. So it has all of the same contraindications and warnings as the other two orexin antagonists. These are all the things like daytime effect, so next morning effects. They've done driving studies with this one. It definitely did impair driving. So there definitely is some next day effect, even if subjectively people didn't report it. It's contraindicated in narcolepsy. They all are. There's drowsiness, falls, the sleep paralysis with this class, cataplexy, some of those things, same. Everything with this class, it has the same class labeling, and all of the same events have been reported with this agent. Also, all of them have the CYP3A4 drug interactions. That's across the class, so no differences there. And the dose is 25 to 50 milligrams within 30 minutes of going to sleep. Pretty much like all of the other agents in the class, except for that little bit shorter half-life, which we don't know clinically yet if that is going to be relevant. So it looked like there were still same next day effects, but maybe subjectively some patients would report less. And then it looks like it helps maintain sleep, even with the little bit shorter half-life, because it's not a real short half-life. So the drug is definitely still on board. So next question, compared to lemborexant and suvorexant, which of these is true about daridorexant? Yep, great, okay. Lots of, has a shorter half-life, which, yep, is the only difference. Another class of drugs that is growing rapidly is the CGRP receptor antagonists. So we have both our IV agents that bind CGRP, and then we have our oral agents, and all of these are used in migraine, either for prevention or treatment. This is the newest addition to the class, so attegopant, Qulipta, which I haven't been saying all of the brand names, but as we go through today, I think if you pay attention to some of the brand names, there is a definite trend towards increased use of Qs this year, either at the beginning or in the middle, sometimes without the U, but Q seemed to be the letter this year. So this product, Qulipta, is the newest addition. Comes in 3 strengths, 10, 30, and 60 milligrams. It's 1 tablet daily, and it is for prevention of episodic migraine. So you can see the alternative agents in the class up there. Rimegepant has both the prevention and treatment indications now, and ubrogepant is just for acute treatment at this time. Efficacy data-wise, these are results from a meta-analysis, and this is specifically for monthly migraine days, and they just show that based on the studies, you can see all of the studies, the green box, individual study results, the diamonds are showing the overall result combining those studies. We saw a reduction in monthly migraine days with across the board, regardless of the dose, 10, 30, or 60 milligram doses. So all of the doses looked to be effective, and the results were almost identical then for medication use. So needing additional medication, so this is prevention, acute medication use was reduced across the board, and the percent of patients who were responders, so a 50% decline in monthly migraine days was similar across the board with the 3 doses. So we have 3 doses, and we don't really have specific guidelines on when to use which. So there are some specific requirements in patients who have drug interactions, in patients with some renal or hepatic impairment, we might want to use the lower doses. But if you have a patient without those, we don't have specific guidance on whether you should start somebody with the 10 and see if that works, or should we bump up and use the 30 in everybody? We really don't have a good feel for that at this time. Fortunately, they are priced the same, so that isn't going to be one of the deciding factors. But there really isn't any strong data suggesting that everyone should start with 30 or everyone should start with 60. Right now, we don't have that information. We have 2 new products this last year for ADHD. So the first one was viloxazine, and this is for pediatric patients. And this is a selective norepinephrine reuptake inhibitor. So most similar to atomoxetine or Strattera, most similarities there, as opposed to the stimulant medications. Comes in extended release capsules. This has been available for, might be overstating this, probably the 20, maybe 40 or 50 years. Think about that. In Europe as an antidepressant. So we have a huge body of evidence for this drug as an antidepressant, but this is a new indication. So it's an antidepressant, it's immediate release dosage form. It's been available for in Europe for years and years and years. This is an extended release dosage form, and right now it's indicated in pediatric patients, although there are studies ongoing in adults, and we probably will see that expanded at some point. The efficacy, not going to present the results. They were all placebo-controlled trials. All 4 of the studies that got this drug approved, it showed improvement in ADHD symptom rating scales compared to placebo. They were statistically significant. There were no head-to-head studies with other ADHD therapies. So difficult to put into perspective how well it's going to work compared to others. It is a strong CYP1A2 inhibitor, so there are contraindications there with other medications like that, and then the monoamine oxidase because of the blood pressure concern. Cautions, so suicidal ideation and behaviors, remember this is an antidepressant, so we do have that labeling here, but we also did see some increased risk of suicidal ideation and behaviors in this population. So even in these pediatric patients with this drug for that indication. So it is something to be aware of. It's not just because of the antidepressant effect. So cautioning patients on that. Screening, if they have a history of suicidal ideations already or severe depression, or if they have family members with some of these conditions. Blood pressure and heart rate increases have definitely been seen with this class in these pediatric patients as well. So keeping an eye on that, monitoring blood pressure and heart rate prior to starting the drug. There was a pretty big group of patients, probably 10%, who had a 20 beats per minute increase in heart rate and a 5 to 10 increase in their blood pressure. So these can be pretty substantial increases depending on where someone is at baseline. So something to be aware of there. Activation of mania and hypomania could occur. So again, that family history or personal history if they have potential for a bipolar disorder particularly. And then there is some somnolence and fatigue. And you can see somnolence, 16% is the most common side effect. So some of the things to be aware of there. They also, the decreased appetite. So it's not a stimulant, but we did see decreased appetite and there wasn't as much weight gain as in the placebo group. So it can affect that. Probably not to the extent that the stimulants do, but there definitely was some impact there. And then there's another new dosage form. So dextroamphetamine was also approved just recently, a couple weeks ago, in a new transdermal dosage form. So we have a couple transdermals now that could be used in patients with ADHD, and this got approval both in adults and pediatric patients. It's labeled per 9 hours in terms of its strength. So it has 4 strengths, 4.5 milligram, 9 milligram, 13.5, and 18 milligrams per 9 hours is how those are labeled. And the intent is that it is applied for no more than 9 hours. So apply the patch. It'll take effect, have onset within about 2 hours. So you try to put it on about 2 hours before you want them to have that effect. And then take it off at 9 hours or earlier. It'll have, if it's left on for the 9 hours, you'll have about 12 hours of activity. So if kids heading off to school at 8, want to slap that patch on at 6, you probably want to take it off again around 3. So that is something to keep in mind if this is going to be used in children, does that work with the situation, the family dynamic, the child care providers, those kinds of things, because patch does need to get taken off, or we probably will have some difficulty sleeping. Can't be substituted milligram per milligram with other products, basically going to be titrating. So just starting with that 4.5 milligram and titrate up. And then we have, I've talked about this product for several years and it finally did get approved, mostly warning about the possibility for drug interactions. And so finally is approved, it is available, and I definitely just want to emphasize those drug interactions again. So this is olanzapine, same olanzapine, works like olanzapine. They've done the head-to-head studies of this combination with the samidorphan versus olanzapine, same effect. So the effect in schizophrenia and bipolar disorder is the same. The samidorphan doesn't reduce fat or anything like that. What it is designed to do is reduce the weight gain and hopefully the metabolic effects that we see with the olanzapine. Unfortunately, at this time in the studies, they did see less weight gain. They did see less gain in waist circumference. They did not see a change in glycemic parameters and some of the other concerns, metabolic concerns. So we don't know, were the studies not long enough yet? Is that are those gonna fall in line later and we're gonna see those, or maybe not? Maybe it's just not patients aren't gonna gain as much weight, but they still are gonna go on and progress to diabetes. That's really the unknown at this point. They were also studied in patients who hadn't already been on olanzapine. So we don't know what the impact would be switching somebody who's already on olanzapine, gained some weight, had those metabolic changes. If we switch them to this, we don't know if we're going to see improvement. We don't know if they're going to lose that weight or have improvement in those metabolic parameters. So that's really an unknown at this time. The price of this product is 100 times more than olanzapine. So another factor to keep in mind with that lack of information about outcomes. And then really the huge caution is the opioids. And so because this is an opioid antagonist, if you start this on someone who's already using opioids, either illicitly and you don't know, or they are using it therapeutically and you just aren't aware, you're going to trigger withdrawal. So the first thing is absolutely make sure that they are not on an opioid already, because you can trigger withdrawal in those subjects. The other thing is if they are on this, they need to be willing to tell people that. So it's really important if they're, you know, in an accident or something like that, and they go to the emergency room, it's going to be important for people to know that they're on this drug, that they're on an opioid antagonist, because that is going to impact their ability to receive an opioid and have improvement in their pain. So higher doses are going to be need to be used. If pain needs to be treated with an opioid, it's probably going to need to be in an inpatient setting, so we can monitor the patient really closely, because we're probably going to have to push the dose initially. And then also, they need to be aware that if they do on their own push the dose, there is the risk then with withdrawals. They could be more sensitive at this point to opioids than they were historically if it is somebody who had used. So to me, there's just these huge opioid red flags, definitely, that we really need to be aware of, and patients need to really understand how critically important that is if they're going to use this agent. So speaking of the metabolic and some of the lipid effects, we have a new drug for hypercholesterolemia that was approved this year, and this is inclisiran, or Levien, another Q without a U in the middle of a word. This is for heterozygous familial, I should say familial, sorry, familiar, familial hypercholesterolemia or atherosclerotic cardiovascular disease. So patients who have atherosclerotic cardiovascular disease and haven't responded adequately to a max dose statin can be treated with this. It doesn't have to be just with the familial hypercholesterolemias. This is a PCSK9 targeted small interfering RNA drug. So we have, and on the next slide, I have the comparison with the other PCSK9 drugs, but this is working at the level of the mRNA. So this is blocking production of PCSK9 rather than blocking the activity of it. And so it's working in a unique mechanism. Comes in a single dose pre-filled syringe, 284 milligrams. And dosing will be on the next page, but it's the same dose for everybody. It's administered subcutaneously, and it is by a healthcare professional. And this is possible because it is only administered every 6 months once they are on regular therapy. So it's a subcutaneous, get the first dose, then 3 months later, another dose, and then it's every 6 months after that. So at this time, it is still advised for administration by a healthcare professional rather than self-administered like we see with the other PCSK9 agents. So this is comparing the others that are available, alirocumab and evolocumab. These are also subcutaneous administration. These can be done by the patient by themselves. They're given more frequently, every 2 to 4 weeks. Really similar though in terms of the cautions with this agent. Pretty well tolerated. It's very effective. So these 3 studies, there's Orion 9, Orion 10, Orion 11. There's also an Orion 4. There probably is an entire Orion series. I didn't pull them all. Orion 4 is the outcome study. And so this is going to look at the long-term cardiovascular impact of reducing LDL cholesterol using inclisiran. So we have that data with the other PCSK9 inhibitors starting to come forward. So we do have outcome data. So they have expanded indications. This one is just right now labeled, like all of our other cholesterol agents when they first get approved, that they state to lower LDL cholesterol in patients with either high cholesterol, the familial hypercholesterolemia, or with atherosclerotic cardiovascular disease and a high LDL. So right now, that's its indication, and pending the results of the Orion 4 study, where we'll get some outcome data that could be expanded to reduce the risk of MI and stroke and some of the other outcomes that we see with the other agents. These 3 studies, Orion 9, 10, and 11, were really similar. They just use slightly different populations. So most of them, the first one was the heterozygous familial hypercholesterolemia. The other 2 were patients with atherosclerotic cardiovascular disease. All of them were in combination with a high-dose statin, or maximally tolerated in some cases, but about 99% of the patients were on a statin in all 3 of those studies. In the first study, Orion 9, in the familial, many of them were also on ezetimibe. The Reduction, though, in LDL cholesterol was consistent across every study. So when added to a statin, we had about a 50% relative reduction compared to the placebo group. So the LDL, a further 50% reduction beyond what they had seen with the statin. So pretty consistent with what's seen with the other PCSK9 drugs. So this is just another alternative in that area. No contraindications or warnings in the labeling. So like the other agents, pretty clean. The others have hypersensitivity. This one doesn't even have that at this time. That is something we could see later. Do recommend discontinuing therapy if the patient is pregnant, consistent with cholesterol lowering therapies. And the adverse reactions were just injection site reactions primarily, and then lower incidences of arthralgia, urinary tract infections and diarrhea, bronchitis, pain in the extremity, and dyspnea. Really low incidence with those. So really the injection site reaction was the primary adverse event. We have no head-to-head data yet with this compared to the other PCSK9 inhibitors. Finerenone was approved last July, and I'm going to talk a little bit about this drug and provide a little bit of data, but I'm going to leave it to the next speakers to provide a little bit more information on its place in therapy. It is indicated to reduce the risk of kidney function decline, kidney failure, cardiovascular death, non-fatal MI, and hospitalization for heart failure in adult patients with chronic kidney disease associated with type 2 diabetes. So this is an incredibly specific indication, but it is patients basically with chronic kidney disease associated with type 2 diabetes to improve all of those parameters, which is based on the results of the Fidelio DKD study, which is the study that got this drug approved. So based on the results of that study, it was submitted to the FDA and received priority review for that specific indication. There are some other studies, and so we will likely see a broader indication as that data goes to the FDA and is reviewed. But right now, it is chronic kidney disease associated with type 2 diabetes. It's a non-steroidal mineralocorticoid receptor antagonist, so an alternative to eplerenone and spironolactone in that sense, in that it's non-steroidal now, as those are steroidal acting agents, and it is an oral agent. So this is the results of one of the other studies that was conducted with this. So there were two studies that were conducted basically side by side at the same time. They're huge studies, both of them. This is the one that was looking at the cardiovascular endpoints primarily. And so this is 7,000 patients with chronic kidney disease and type 2, and looking at the impact on hospitalizations for heart failure. And so they saw a reduction in that. They did not see a lot of severe adverse events. So hyperkalemia is really the biggie. And so that's the thing to watch out for with this drug. But this was in addition to its use with an ACE or an ARB. These were patients who were being well managed already. At the time, the SGLT2 inhibitors weren't widely used, so very few patients were on those. So that is one caveat with that. And then this is what's called the results of the fidelity analysis. And so this is the infographic basically from those investigators. But this was a pre-specified pooled analysis of both of those studies. So we have a huge number of patients with type 2 diabetes and chronic kidney disease, did not have heart failure upon an enrollment in these studies, were randomized to finerenone or placebo. They looked at the kidney outcomes and the cardiovascular outcomes in this. And so you can see in this study, these patients, they were on ACEs or ARBs, 99% of them, 72% of them were on statins. They were not in perfect control with their hemoglobin A1C. So these patients had a hemoglobin A1C of 7.7. But you can see a little bit more about these patients. But really what they wanted to point out was there were good cardiovascular outcomes and there were good renal outcomes. And so there was improvement in all of those areas. And so there was a reduced risk of both cardiovascular and renal outcomes. And there was some hyperkalemia. And so that is something to be aware of. So definitely something to be keeping an eye on. It was an issue. It was a low discontinuation rate, but it did require discontinuation in some patients. So that is really the key thing in terms of side effects to be watching for. It does have some drug interactions as well. So CYP3A4 again comes up, but hyperkalemia again, really focus on that. 18% of patients had hyperkalemia. Other things were not seen very often. Amongst those drug interactions, grapefruit juice, remember that is a 3A4, so that does fall into this. Make sure patients are counseled to avoid grapefruit juice. And it is dosed orally once daily, 10 or 20 milligrams, depending on the renal function. So there's specific guidance there. Not recommended if the GFR is less than 25. So another question on Lecture Panda. Yep, okay. Choice B, chronic kidney disease and type 2 diabetes. So we might see it expanded to some other indications. But right now, that is the population that has been studied for, looking at both the cardiovascular and the renal outcomes. There's been lots of other indications revised for the SGLT2 inhibitors, but just wanted to really mention this one because it kind of ties together with that finerenone. And so dapagliflozin got an expanded indication to reduce the risk of kidney function decline, kidney failure, CV death, and hospitalization for heart failure in patients with CKD at risk for disease progression. Not specifically type 2 diabetes, but that is the population where it is largely used. So all of the agents in that class are seeing expanded indications. So really it is that figuring out which agent's going to be the best choice depending on the patient's other risk factors, other disease states, drug interactions, and ability to tolerate a therapy. But that's just one example of that broadening indications that we're seeing in that particular class, which is pretty extensive now. And then we had 2 new formulations of insulin glargine approved. So Lantus biosimilars. We have Resvoglar by Lilly, which is a biosimilar. So could be prescribed under that name as an alternative. And then we have Semglee by Mylan, which is the first interchangeable biosimilar that we've seen in the insulin group. So this one can be switched. It's interchangeable. Think of it as a generic rather than just a biosimilar essentially, although notification may still be required depending on state rules. And so, but they've submitted additional data. So the biosimilars submit data showing that, 1, their levels are going to be similar. 2, they go beyond that and they show they actually do have efficacy. So they have to show more than we do with traditional generic drugs where they just have to show that the levels are the same. But now with interchangeable, they can actually show, they have to do studies that show that a patient can be switched and switched back and that there's no change in their clinical. So it's not just head-to-head versus the main product, but they actually have to be able to be switched back and forth and show that there wasn't a change in their condition. So that's an interchangeable biosimilar, and those are listed separately in the purple book. So remember our guide to biosimilars on the FDA is to go to the purple book, and they'll list the biosimilars, but they'll also list the interchangeable biosimilars, which then can be substituted. And while we're on this class, we have a new a new indication and dosage form of one of the GLP-1 receptor antagonists, semaglutide. So Wegovy is the brand name for the weight indication. So this was indicated for chronic weight management for patients with a BMI over 30 or over 27 with some additional risk factors such as hypertension, type 2 diabetes, or dyslipidemia. The doses are a little bit higher than what was used for the diabetes indication, although they've newly approved a little bit higher dose, I think the 2 milligram. So we are seeing a bump up in that dose as well. Cautions are the same as for the diabetes indication. So these are patients that, they don't have to have diabetes. These are for patients who are using it for weight management. The subcutaneous injections, dose titration, again, same thing. You want to start slow because of the GI side effects and slowly titrate people up. And there is actually a shortage right now. Just saw that this week for this particular product. So the 2 lowest doses, the 0.25 and the 5 milligram, are not available and probably won't be until the second half of this year. Won't be able to start new patients probably on this, at least easily right now, depending on the shortage and availability. So if you were looking to start somebody on this, they may need to wait a little bit until we can get them the beginning doses for the titration. Patients already on it, they haven't had any shortages. With the higher strengths, apparently it's a manufacturing issue right now with the lower strengths. Do I need to ignore the warning I just got on the screen? Okay. So the data for the weight indication is from the STEP 8 study. This is patients who did not have diabetes. Mean age 49, mean body weight was 104 kilograms, BMI was 37.5, so well above that threshold for what qualifies for starting on it, but that was for the inclusion criteria to get into the study. Primarily white subjects, 74% of them were white, mostly females, and most of them had dyslipidemia or hypertension as their common comorbidities. So the difference, this was a head-to-head study versus liraglutide. So we have placebo-controlled studies, but we also had this huge study versus liraglutide, which gave us some really good perspective then compared to the other GLP-1s. The body weight changed, so they had an additional reduction of 9% reduction, but they also, the number of participants who had at least a 10, 15, or 20% reduction was substantially greater with the semaglutide, which is administered weekly. So the odds of achieving those endpoints were increased quite a bit. It was significant for all 3 of those endpoints. So a 20% weight loss is definitely a substantial weight loss. 10% is usually what is considered effective if something achieves a 10% weight loss. So we were seeing some pretty good results in this study, a much higher percentage of patients achieving a 20% weight loss. Okay. And adverse events, this is again head-to-head both with liraglutide and placebo. So you can see the GI, no surprise there, is going to be the most common side effects. So the nausea, constipation, diarrhea both occurred pretty frequently. Nothing really surprising in terms of the adverse events. And another agent that we'll see in the patient population with diabetes, so back to diabetes, dasiglucagon. So this was approved in March. It's another glucagon agent. So this is a glucagon receptor agonist. It's an analog of glucagon, but another alternative. So we've gone from just 2 or 3 years ago having only the kit where people had to draw up the dose, dilute and give a dose if we wanted to give glucagon in an emergency, to now having a pre-filled product, this product that is available pre-filled and ready to go, and a nasal. So we have lots more alternatives available. And really the advantage to these is all in that administration. So if someone is in an institution and they're qualified to draw up a dose and prepare a dose, then there really is no difference. It doesn't matter. But if you're looking for something to send home with someone, if you're looking for something that, a family member is going to possibly be giving who isn't a healthcare professional and has no training, adding in the stress of having to prepare a dose for somebody who's having an emergency, these just provide that additional ease and comfort in providing the dose easily. And so they all work. They haven't been compared head to head, although they've all been compared to the original glucagon kit. The median time to recovery is 10 minutes. With glucagon, it was 12. So they all fall within the same line. You can repeat the dose once after 15 minutes if they haven't had an adequate response. Regardless, as soon as the first dose is administered, family members need to be advised to call for emergency help. So this isn't something that we can just let go. Nausea and vomiting are super common afterwards, as with all of the glucagon formulations. And oral carbohydrates should be administered as well as soon as possible, since the person does respond. Next, move to a new oral contraceptive. So drosperidone's been around. We've been using that. It's anti-androgenic, progestin, good activity, good history, useful in, obviously as an oral contraceptive, but also has an impact in acne and some of these other uses. This is just a combination with a new estrogen. So this estrogen, estetrol, is a synthetic analog of natural estrogen. It's an estrogen that's present in the fetal human liver. So this is an estrogen that we see in pregnancy and then in the fetus, but goes away after that. So it's E4 is what it's called. This one is being synthesized from a plant source. So I know that's always a question that comes up, is what was the source? Is the plant source that it's been derived from. And so it's thought that it might have less impact on breast tissue and on bleeding parameters and thrombosis. That has not been verified in clinical trials. So right now, class labeling, this is an oral estrogen progestin combination oral contraceptive, all of the same warnings in terms of thrombosis and risk factors and age factors and all of those things. But the thinking is that it's possible that it might have less of a thrombotic potential. Has not been validated yet. So, but that is kind of the interest, and that's what prompted development of another oral contraceptive. 24 active tablets, 4 inert. So no information yet on giving it continuously. So the 4-day inert tablets, so you have the withdrawal bleeding. It was effective. It was pregnancy rate overall was 2%, which is in line with what we see with other oral contraceptives. None of them are perfect. None of them are 100%. Bleeding was as expected as well. So there were a fairly common incidence of unscheduled bleeding. So during that first month, especially, a lot of people had breakthrough bleeding, declined over time, as we see with all of them. So not a huge difference there. Pretty typical right now, oral contraceptive, until we get more information. Abrocitinib is a new Janus kinase inhibitor, and this one is for the treatment of atopic dermatitis. This was held up for quite some time. So the Janus kinase inhibitors have a variety of indications that they're being used for right now, obviously. Rheumatoid arthritis, but also some myelofibrosis and some other conditions. And we've definitely seen an increase in toxicities as the products have been around. So we've seen the labeling change. We saw the box warning get added, and we saw lots of new information about some cardiovascular impacts. And so these products had also been being studied in atopic dermatitis or eczema, and it had submitted to the FDA, and the FDA kind of put them on hold for a while. So while they were weighing through all of that toxicity information, they're trying to also balance it with how safe then are these products if we're going to be using them for atopic dermatitis, which is a generally milder condition than some of the other conditions that it's being used for. So not necessarily a life-threatening condition, for instance. So that risk versus benefit. So they've been trying to weigh that. So right now, they did finally approve these products. They do have some pretty restrictive labeling in terms of those warnings. So this one got approved for refractory, moderate to severe atopic dermatitis. Right now, it's only indicated in adults. There are some studies in 12 to 17-year-olds, but it did not get indicated for that population, at least at this time. And it's for patients who are not controlled with other systemic therapies, including biologics, or when their use is not advised. So this is definitely not the first thing to go to after a corticosteroid didn't work. Usually they're going to probably go to some of the other biologics who do have less toxicities at this time than the Janus kinase inhibitor class, at least until we weigh out how much the risk is in this population. So efficacy, a lot of words on that slide, I apologize, basically just showing that, yeah, there was some treatment success. So clear or almost clear is the endpoint we really want. That's the main parameter they were using. They also use the EASI, Eczema Area and Severity Index, and you want to get 75% or 90% improvement in that. So they were using 75. So these were the primary endpoints in both these studies, and we see some pretty good response at both doses compared with placebo. We do see a better response at the higher dose. So there was definitely a dose-related relationship there. And then this was the JADE Compare study, which actually compared it with dupilumab. And so can see that the green is the dupilumab, the abrocitinib is the blue and the orange. And so we see pretty similar responses really in terms of those, both better than placebo. So dupilumab is another biologic that is commonly used for a lot of different things, but one of those being atopic dermatitis where it is indicated. So like I said, they did get the class labeling. So contraindicated with antiplatelet therapies during the first 3 months, definitely some bleeding risks there. And then all of your boxed cautions. So infection risk is a biggie, risk of malignancy has been seen with this class, major adverse cardiovascular events, and again, the thrombosis risk, which is probably tied to that adverse cardiovascular events. So definitely something to be aware of and weighing that risk versus benefit in this population. So what are the risk factors do they have, and how severe is the atopic dermatitis? Other side effects, pretty mild nasopharyngitis, nausea, headache, herpes simplex was increased as well. And so that is tied again to that infection risk. So we do see increased infection, monitoring their blood counts, monitoring lipids, saw increase in lipids. Lots of drug interaction potential, and lots of adjustments for dose. So typically you're going to use 100 milligram for most patients. That can be bumped up to 200, which was more effective in the studies if they're able to tolerate it. But in patients with moderate renal impairment, if they're on some CYP2C9 inhibitors, or you think they might be a CYP4 metabolizer, CYP2C19 4 metabolizer, use the 50 milligram dose, max is 100 in that population. So there are some populations where we don't want to use the 200 because of that risk of side effects. And another in this class, so ruxolitinib, which is also used for some other indications, myelofibrosis and so forth. Is it also a Janus kinase inhibitor? So they developed this as a cream, hoping to avoid some of those systemic effects, but it is actually absorbed. And so it does have the potential for all of those systemic effects as well. So this did get indicated about the same time. So again, they finished up that review of the Janus kinase inhibitors and did go ahead and approve this for mild to moderate atopic dermatitis. Patients 12 and older, so it did get the slightly lower age group, including those adolescents, and those not responding to topical therapies. So not recommended in combination with another biologic, and definitely not with another Janus kinase inhibitor. this is an alternative and may be useful in patients who aren't responding to other therapies. It's also being evaluated in vitiligo. So they had some pretty good data there, up to 50 to 75% improvement in vitiligo symptoms. So the FDA is reviewing this right now, and we could see this one approved in the near future for that. Again, that risk versus benefit discussion is part of what may hold up that approval. Efficacy, basically they studied it versus placebo, so we don't have a lot of information here, but it did look like it was successful. They had clear or almost clear skin in about 50% of patients, obviously compared to a much lower end group with placebo. Cautions again, as for the class. So as if this is an oral Janus kinase inhibitor. So even though it's a cream, even though it's topical, we still have to be concerned about the infection risk, adverse cardiovascular events, malignancy, and thrombosis. Thrombocytopenia, anemia, and neutropenia also were seen, even with the cream. And so again, we do need to look at the complete blood counts. We're seeing those across the board with this class. It's applied to the affected area up to 20% of the body surface area. So again, this is systemically absorbed, so we don't want to apply this to the entire body. So this is for patients where up to 20% of the body surface area is either affected or only is going to be used to treat a small area. No more than 60 grams of cream per week, because we don't want to expose them to more drug. And they should stop when the symptoms resolve. So this is for, go back to that. That indication was for short-term, non-continuous treatment of atopic dermatitis. So the idea here is these patients did see some clearing, quite a few of them. If that's the case, then once they're clear, stop using it. And then we can repeat it. It's just a not continuous therapy. So if they clear, we don't need to keep using it. Stop for a while, and hopefully we can mitigate some of that risk in doing so. And if they don't see improvement within 8 weeks, then discontinue therapy. It's not worth the risks, and look to some of the other therapies that are available out there. And another agent that got approved for atopic dermatitis. This was a big area. So tralokinumab, this is an IL-13 antagonist, so more similar to the dupilumab. We're away from the Janus kinase inhibitor class here. This was indicated with or without corticosteroids, and comes in a pre-filled syringe. Patient can self-inject. It's every other week. And those are I guess, the key points. The interval can be extended. So you start out every other week. After 16 weeks, if they have good clearing, they can increase it to the interval to every 4 weeks. These are the results of the studies. These were placebo-controlled studies. Again, looking at clearing and how many patients achieve clearing or clearing responses. So how many achieved the 75% clearing or a total clearing on the top one versus placebo. So we did see an increased response at 16 weeks. See them break away pretty quickly. So pretty quickly you'll know if somebody's going to respond to it or not. Results were maintained to week 52. So this is only showing results to week 16, but it was effective and studied out to 52 weeks. So they did see patients maintained clearing out that long. They've also studied this in asthma and saw really mixed results. So I'm not sure what other indications we may see down the line for this product. You know, a lot of the products in this category do have multiple indications. At this time, really, this is the only one. We don't have really great data on some of the others yet. So at this time, hypersensitivity has been seen. So just something to be aware of and not to continue if someone hasn't developed a hypersensitivity reaction. Conjunctivitis and keratitis were also seen. And these resolved with continued therapy in the majority of patients, but something to monitor for if it doesn't resolve, if they don't see improvement, then discontinuing therapy. And you can see that the conjunctivitis was in about 7.5% of patients versus 3% of placebo-treated patients. So there definitely was an increase in conjunctivitis there. Helminth infection, that's the standard. If a person already has the infection, treat it before you start any of these agents, like the dupilumab in this one. If they develop an infection and it's not responding while they're on this drug, you might need to stop it, treat it, and restart. Pretty rare occurrence, but a possibility. And then making sure that they've received any of their necessary live vaccines before you start therapy, because they probably won't respond while they're on it. Adverse reactions there versus placebo. So really the conjunctivitis is the kind of unusual and one to definitely be aware of. Can be used with and without topical corticosteroids. So it was studied in both. One study was with, one was without. So we definitely have that data. But the calcineurin inhibitors limit that co-administration. So those can be used, but just in really small areas. So maybe if they're face and neck, or some of those areas that are particularly slow to resolve to therapy, you can go ahead and use them, but it's not recommended to use them in conjunction widely. And another specialty drug, as most of these have been for the last little bit here, tezepelumab was approved in December as an add-on maintenance treatment for severe asthma. And so this is a new class of medication. This is what's called a thymic stromal lymphopoietin targeted monoclonal antibody. TSLP is what it's targeting. And this is it's an epithelial cytokine at kind of the top of the whole cascade. And so it looks like it's going to be effective in eosinophilic airway conditions, asthma, also some other eosinophilic conditions we may see. So we'll likely see some expanded indications at some point. Did see reduced asthma exacerbations with this. So it showed a 66% reduction in asthma exacerbations in these patients who had severe asthma. So this was a patient population that was, controlled using all the controller meds. Add this on, they saw basically reduction in asthma exacerbations, severe exacerbations from 2 a year in the group that didn't receive this to less than 1 per year in the group that did. And again, those were the severe exacerbations. Same cautions as we just saw on the last drug in terms of hypersensitivity, the helminth infections, and the live vaccines, making sure they're up to date on those before you start it. It is subcutaneously every 4 weeks, and it is administered by a healthcare professional. So another restriction there. But the side effects in general weren't particularly of frequent incidence. So which of these drugs is not indicated for atopic dermatitis? Yep, that last one, tezepelumab. So those names are pretty similar though, the tralokinumab and the tezepelumab. Lots of similarities. There were a couple of other drugs that had really similar names this year. When we get to the orphan drugs, you might see a couple of those that look pretty similar too. So the other 3, A, B, and C, were indicated for atopic dermatitis. So next, I'm going to talk a little bit about aducanumab. Interesting drug for Alzheimer's disease. You've probably all heard about the controversy. Really interesting whole entire process of approval and very controversial, and could talk for an hour on this one alone, but I won't. But it was approved in June, received the accelerated approval that I'm sure you all heard about. It was initially indicated just for the treatment of Alzheimer's disease. About a month later, the FDA came back and said in patients with mild cognitive impairment or mild dementia, because that was the population it was studied in the clinical trial. And so to be consistent with their usual process, you usually only approve a drug for the indication that was studied in. They came back and relabeled that. So that was good to see. It is an amyloid beta targeted monoclonal antibody. And in the clinical trials, it did reduce amyloid beta plaques in the brain. So that data is not necessarily the point of contention. That was seen. It's just that we really still don't know that that isn't reliable surrogate marker for clinical improvement. So that has not been validated. So it is dosed IV every 4 weeks, titrated over 6 months. They start with 1 milligram per kilogram. The goal is to get to 10 milligrams per kilogram every 4 weeks. And as you're probably aware, use is pretty limited so far. Coverage decisions have primarily influenced that. And those are largely a result of the clinical trials that are out there. So there were 2 studies. There was the eMERGE trial and the ENGAGE trial. And these are available on the FDA site. The FDA's review is all there. If you want to read the results of these studies and see the data, it is there on the FDA site. They were also just published in a journal, the Journal of Prevention of Alzheimer's Disease, which is not one of our huge journals. And that was also another point of criticism, is that this data didn't end up getting published in a typical journal that you would have expected for this high profile of a drug and disease. And so what they saw was the eMERGE trial, 1,600 participants. The high dose arm did report lower rates of progression of disease. So they slowed the progression of Alzheimer's. This was only seen in the high dose arm, not in the low dose arm. And keep in mind that both of these studies were actually discontinued early because at the interim analysis, there was a futility analysis. And basically they were like, there's no way they're going to show efficacy. Stop the study now. It's not worth the risks. So they stopped all these studies. And then they went back and looked at the data and they said, oh, but look, in our 10 milligram arm, we did see a decreased rate of progression. They also talked about a lot of the secondary endpoints, but this study wasn't designed to evaluate those if they didn't meet significance on their primary endpoints at both doses. And so that's another criticism, is the published version of this study ignores that and presents all the secondary results with statistical analysis as if those are valid. But their protocol did not allow for that. So more areas of kind of controversy really arising the more this product is around even. So the second study didn't show any differences in either the low dose or the high dose arm. In both studies, there were protocol changes throughout. So even though they stopped early, up till that point, they were changing their protocol. So that's another criticism of the study, is they were changing the doses. They changed the high dose group from 6 to 10. There were things like that that were going on. So the data is just really messy. It's not conclusive at all. The part that is conclusive is the safety data. So we do know that these cause what are called amyloid-related imaging abnormalities, or ARIA. And you can see these on an MRI. And in some cases, these abnormalities don't have any clinical impact that we know of. In others, they cause a lot of symptoms. So they're like, some of them are microhemorrhages. So we're actually seeing bleeding. Some of them are edema, and we're seeing confusion and dizziness and delirium and those kinds of symptoms, which in this population can be really hard to figure out. So individuals who are going to get these drugs do have to be monitored with an MRI. So there has to be a brain MRI done before you start the therapy at some point, at least within a year of starting therapy, and then at fixed intervals during therapy. So definitely have to be looking out for that. I have to be really cautious on that bleeding risk, especially. There have been some fatal instances. So this particular event can be fatal. And then patients who were in the studies weren't allowed to use anticoagulants or antiplatelet agents or immunosuppressive therapies. So being aware of that. So those aren't necessarily a contraindication, but we just don't have any data. So whether those are going to increase that risk further of microhemorrhages, you would suspect, but we really just have no data. And so it's really you'd want to be very cautious in using any of those. So there are, when I get to the products that are under review right now, there are 2 other products under review, back up, for Alzheimer's disease right now that have been submitted, and they submitted because of this data. So they saw this product got approved. We're going to go ahead and add our data in there too, because look, we decrease amyloid plaques. And so we might see those products. The FDA is going to have to address them at some point. And is this something that they're going to be willing to keep approving based on these surrogate endpoints? Also, because this was an accelerated approval, the company has to complete a clinical trial. And so they did finally submit their protocol this month or last month, March, to the FDA. And they will be done with their study by about 2023 or 2024, which is an improvement over what they had originally said. So it looks like it's going to be done in 3 or 4 years. They were initially saying it was going to take them 9 years to complete the trial. So we may have some efficacy data in 3 or 4 years. Moving to multiple sclerosis. So we had another ponesimod, another sphingosine 1 phosphate receptor modulator. So this one is specific to the receptor, the 1 type. So the first agent we had in this class worked on 1, 3, 4, and 5, and it had a lot of side effects. And then we had 3 other agents approved, or 2 other agents that were just 1 and 5. And now this one's just 1. We don't know the clinical significance of that. So is the just targeting 1 going to have fewer side effects or better safety than the 1 and the 5? We don't know. Is it going to have any change in efficacy? We don't know. It's still a little unclear even how these drugs exactly work in multiple sclerosis, but they do appear to have a pretty good impact. We have another in this class. This again is going to be a specialty product, probably limited distribution. At this time, only indicated for multiple sclerosis, although we're starting to see some other indications for some of the other drugs in this class. Cautions, pretty typical of the class, the cardiovascular. So if someone has risk factors for an arrhythmia, closer monitoring for sure at that first dose. Otherwise, just monitoring in general. Blood pressure, liver function, macular edema, fetal risks, all typical of the class. There is a dose titration that's recommended. And again, because of those cardiovascular risks primarily. And then head to head, they didn't compare it to anyone else in the class, as we would expect. But they did compare it to teriflunomide, where they did show a reduction in the annualized relapse rate. So we had a good response there in terms of the response rate. But just no head-to-head with others in this class. So how is it going to compare to the others? Just really no idea at this point. Also saw another new drug approved for lupus, so systemic lupus erythematosus. So this is the second newer indication or new product for this indication. Belimumab was approved a couple of years ago now, and has since then had an expanded indication to include both SLE and lupus nephritis. This one right now is only indicated in SLE, moderate to severe, people receiving all of the standard therapies. So as you would expect, hydroxychloroquine, potentially glucocorticoids, at a low dose, maybe other immunomodulators have been tried or are being used concurrently, and then adding on this if they're still having pretty active disease. So it is administered as an IV infusion. There is an infection risk. There's hypersensitivity risks. There is a subcutaneous injection form being studied. So it could be that will be ultimately able to be administered by patients. But right now, that's not the case. Infection risk is really the biggie. So making sure everyone's up to date on their vaccinations prior to initiating, as with all of these immunomodulators. It is a little bit different class. So this is an interferon receptor antagonist. And the results of the studies, there were 2 big studies. It was TULIP 1 and TULIP 2. Saw about a 50% reduction in relapse in one of the studies, and in the other one they did not. So they saw improvement in a lot of the secondary endpoints, but not necessarily in that primary endpoint. So it's not overwhelming data, but it did look like it did reduce some of the flares. There was an increased duration of time before they experienced a flare, and fewer flares experienced annually. But it was definitely used in combination with other therapies, including immunosuppressants, just not other biologics. So methotrexate, azathioprine, those kinds of things, along with the hydroxychloroquine. And no data yet in lupus nephritis or in CNS lupus. 3 products got approved for itching besides atopic dermatitis. So we had our atopic dermatitis itching, but we actually had 3 products approved this last year for itching associated with other conditions, which is kind of interesting. This one is for moderate to severe itching pruritus associated with chronic kidney disease. And so these are patients who are on dialysis, hemodialysis specifically, and it's administered at the end of the hemodialysis session. It's about $17,000 annually. So this is a specialty drug. It will be administered in the hemodialysis clinics. It is a kappa opioid receptor agonist, and it does have some CNS effects. So although they say it's peripherally acting, the side effect profile does definitely emphasize some sedation. There's definitely some driving risks, and those risks were seen to be higher in those over 65. So particularly sensitive in the older population to some of those CNS risks. So caution patients about driving for sure, not using other CNS active medications, and to be aware of the potential for fall, dizziness, drowsiness, driving. Definitely a specialty drug. Additional specialty drug, faricimab, is a vascular endothelial growth factor VEGF inhibitor. It also adds in a new mechanism, so this angiopoietin-2 inhibitor. So we have a bunch of VEGF inhibitors that are available now and are used for these ocular conditions. This one adds in an additional mechanism that's supposed to be complementary. Don't know for sure how they're going to compare head to head, whether it's going to have a better response. Did see a prolonged response though. And so patients didn't require those intraocular injections as frequently, which from a patient perspective is definitely a desirable trait for a medication that you have to have injected into your eye. So it's used for both the wet age-related macular degeneration and diabetic macular edema. In comparison to aflibercept, they were able to extend out the duration. So instead of giving it every 4 to 8 weeks, they were actually able to extend over time to giving it every 16 weeks and maintain the same effect. So that is a potential, for sure, benefit for this particular agent. Standard cautions, ocular infection. Of course, you're injecting something into the eye. You don't want to do that if they already have an infection. And then retinal detachment, looking for fusion, all of the ocular monitoring parameters that an ophthalmologist would be doing at the time that they're instilling this into someone's eye. So we also had a biosimilar in this class. So ranibizumab is a biosimilar to Lucentis. And so same indication we just talked about, as well as one additional indication. So this product is a biosimilar that will be available this summer. So if you do work with ophthalmologists or in a clinic that is doing these procedures, there will be a biosimilar now available. We also saw 2 more adalimumab biosimilars approved. So a reminder, we've got, how many do we have now? 7? We have a lot of biosimilars approved to adalimumab, but they are not available yet. So we are getting close. The first one, I believe, is going to launch in January of 2023. So we are approaching that deadline that they've negotiated with the manufacturers. So we could see these finally. I think this one, the Yusimry, is going to come out probably in July of 2023. So we're going to see 1 in January, 2 or 3 in July, a couple in September, and I think 1 in October. So through 2023, all of these negotiated contracts are finally going to come through, and we're going to start seeing biosimilars to adalimumab, Humira. We also saw this product from Boehringer Ingelheim, the Cyltezo, converted from a biosimilar to an interchangeable biosimilar. So now we have an interchangeable biosimilar even for adalimumab before any of them even are out there. So this one had been approved a couple of years ago. and was waiting to launch. And in the meantime, was able to pull together the data showing that they were interchangeable, not just a biosimilar. So this is the first one that will be available as a interchangeable biosimilar. It was first approved in 2017. Now in 2022, it got expanded and will launch in 2023 in July. So we'll have a number of biosimilars by next year at this time. Well, slightly later. We'll have one by this time next year, finally. So which of the following is categorized as an interchangeable biosimilar? Another Lecture Panda question. Okay, seeing a little action there, but yes, the Semglee, insulin glargine is the Semglee is the interchangeable. So there were two new Lantus biosimilars, but the Semglee is the only one that is interchangeable of the biosimilars. The first two, anifrolumab and faricimab, are actually new molecular entities this year, so they're not biosimilars, and they don't have biosimilars available yet. And the last one is a biosimilar, but is not an interchangeable biosimilar. So you can substitute with appropriate permissions granted, not just as you would with a generic. I'm going to go over some things that are on coming soon, potentially. So notification, not FDA approved, may never be. So these are just things that right now are sitting in the FDA. So we have another product for multiple sclerosis. And actually this product, the ublituximab, is under review for a couple of indications. So the multiple sclerosis by September, they'll have a decision on. Earlier this summer, they'll probably have a decision on some chronic lymphocytic leukemia, some additional lymphoma and leukemia indications. So they've submitted for both some lymphoma and leukemia indications and multiple sclerosis. And so we'll see action on one or both of those coming soon. The second product by Amylyx is a combination of two neuroprotectants that are actually compounds that are available already. I mean, they're just using them in a slightly different way. And this is for patients with amyotrophic lateral sclerosis. So this is the big, this is the aducanumab of this year. This is, last year we had the Alzheimer's controversy. This year we get the ALS controversy. So this product was before an advisory committee this week. They did vote that the data was insufficient to support approval, but they voted 6-4, and it was a pretty interesting discussion. So they didn't, with this particular product, see an improvement in a biomarker, but they don't know if the biomarker they were looking at is actually even relevant because it's not been validated in ALS. So there was no change, but they didn't know if that really meant anything. There was a slowing of progression, but whether it was statistically and clinically significant was the question. So the patient advocacy groups were very strong in their hopes that this product would get approved because there really is nothing that slows the progression of ALS. At the same time, the FDA is being under a lot of pressure to not repeat what they did with the Alzheimer situation. And so the data, though, is completely different with this. It's like a different indication, different drugs, work in different ways. So it's something that'll be interesting to see. The FDA could go either way at this point, but their advisory panel, by a small margin, suggested not approving it at this time until the results are available from their further study. They do have a study ongoing, which will be completed in the next 1 to 2 years. So there will be, and they are ongoing with that study regardless of what happens, approval or no approval. That study is going to be completed at least. We also have the 2 products listed below that are for Alzheimer's disease. So again, those have both started a rolling NDA process. So they've started submitting their information to the FDA, and they're kind of waiting to see if the FDA, I guess, what the environment of the FDA is right now and whether they should pursue an accelerated approval, like we saw with the aducanumab, or whether they should just go forward with completing their trials. We have a new GCSF product. So this is a one dose, it's a long acting product. So during each course of chemotherapy, rather than administering it, every day, every other day, things like that, this is just a one dose and then repeat it with the next course of chemotherapy. And it was non-inferior to filgrastim when administered that way. So we'll probably see that review completed sometime here in May or June. We saw a submission for a new antiviral, bulevirtide. This is for chronic hepatitis delta, which coexists with chronic hepatitis B in a certain number of patients, but doesn't exist by its own. So you either have B and D or you just have B. It's a more inflammatory and rapidly progressing form of chronic hepatitis. And so this antiviral did slow that progression. It's an injectable injection. It's given daily for 24 weeks. And it did slow or have a response in about 40% of patients. So it's not a cure, it's not 100%, but we don't have any therapies right now for chronic hepatitis delta. An oral carbapenem, so tebipenem, submitted for complicated urinary tract infections. We will likely see this approved. So this will provide an alternative for chronic UTIs, or at least a follow-on therapy for someone who starts a carbapenem in the hospital and you want to discharge them on the same class of drugs. It was non-inferior to ertapenem in that particular indication. And it's been available in Japan for about 10 or 12 years already. It's available there for a number of indications, not just UTI, and they use it in a broader population as well, pediatrics and adults for several indications. So if this product gets approved, we will likely see expanding indications over time as well. Linzagolix is another GnRH antagonist. This one's being submitted both for uterine fibroids and endometriosis. Right now, the fibroid indication is the one that's likely to get approved first. And they're looking at a couple of different doses. And what's unique about this one is that their lowest dose, they still had a pretty good response rate, but they didn't have to use add-back therapy with steroids, with hormones. So for patients who don't want to be on a hormone, this would be an option compared to the other GnRH antagonists that are out there. And we have another antifungal for recurrent vaginal candidiasis that is under review. Specifically, unlike the other agent, both of those are going to probably be expanding out to looking for that recurrent population as really being their niche. New product being reviewed for generalized pustular psoriasis flares, which is not your standard psoriasis, but this is just it's a completely different form of psoriasis, really, and it's a more extreme, severe type of psoriasis. And it's an IV administration, and they did see pretty good results with clearing on that one. Another topical agent for atopic dermatitis with a new mechanism of action. This will probably be for more mild, both psoriasis and atopic dermatitis. An oral tyrosine kinase 2 inhibitor. And so tyrosine kinase 2 is in the Janus kinase family and kind of higher than that, but doesn't have all of the effects necessarily of the Janus kinase inhibitors. So whether it will have some of those same cautions that we're seeing with the Janus kinase inhibitors is not clear at this time. And it's also being evaluated for several other indications, but right now it's being submitted for psoriasis. And then bimekizumab was submitted, was up for review already, and really the main delay there, the class of drugs that we already have several agents in, it got held up by some manufacturing stuff. So the FDA has basically said, because of COVID, we haven't been able to get to your plant to do the inspection. Therefore, we're not going to approve your drug, which we saw with a lot of drugs. But this one is likely to open up here soon and be able to be inspected and maybe move forward. It was more effective than secukinumab. So if you are working in that specialty area, this one was more effective than the secukinumab in psoriasis. Let's see, the tirzepatides is a GLP-1 and gastric inhibitory polypeptide 1 agonist. So tons of studies with this product, comparing it to the GLP-1s, using it as first-line therapy, using it as in combination with insulins, lots of oral agents, quite a few studies out there, pretty consistently showing a greater reduction in A1C and glucose levels and a greater weight loss than with the GLP-1s alone. But not cardiovascular. Well, one, we don't have endpoint data, so we don't have long-term outcome data with this agent because it is new, but it is in that same GLP-1. So, and those studies are ongoing. And then secondly, the GI side effects are going to be obviously the same as with the GLP-1s and maybe even a little bit more extreme. So something to be aware of there. Teplizumab, pardon me. This is one of those names that's really similar to a couple of them that we already talked about. This is an anti-CD3 monoclonal antibody, and it looks like it may delay clinical type 1 diabetes. So it looks pretty promising that this product will actually get approved. They studied it in patients who had a high risk for developing type 1 diabetes because they had a family member with it and because they also had antibodies already present. So autoantibodies were detected and they had some glycemic, that mild, they didn't have diabetes, but they had impaired glucose levels. And so they gave them this therapy. It's a 14-day course of therapy. It's an injection. And then that's it. It's a one-time thing. You give them that course of therapy and they monitor them. And the control group who didn't get it, 72% of them developed type 1 diabetes, met the criteria for type 1 within 2 years, in a median of 2 years. And so far of the group that got this drug, 48% of them went on to develop it, but it was in a median of 4 years. So not only did we have fewer people develop the type 1 diabetes, but we also, it was several years. So we bought some time. And really that's what the hope is with this drug. In the meantime, maybe we'll find other things that can actually prevent it from happening at all. But in the meantime, if we can delay it, especially in young children, then we're buying time, and that's a great thing. Vadadustat, like roxadustat, got nixed by the FDA, so I just grayed that out. There's concerns both about their adverse cardiovascular endpoints. They weren't able to show non-inferiority to darbepoetin. So this was a really exciting class. Everyone thought, oh, these oral agents are going to be great for anemia and chronic kidney disease. But there's been some concerns for sure about cardiovascular endpoints versus the erythropoietin agents. And this one also had some toxicity in the liver that they were concerned about. So they're going to want more information before either one of those products moves forward. And we have a new proton pump inhibitor, but don't call it that. It's basically what I'm seeing. It's a potassium binding gastric hydrogen potassium ATPase blocker. So they like to call it a PCAB blocker. It's a proton pump inhibitor. It's just working on potassium instead of the sodium. Looks like it works really well. It is acid stable. So that is as a potential advantage is the acid stability. Efficacy wise, looks like it works in all of the same conditions as a proton pump inhibitor. They've done some head-to-head studies against proton pump inhibitors. And administered twice daily, it looks like it does fine. Don't know about the long-term impacts. So absorption wise, we're probably going to have all the same ones we see with the proton pump inhibitors. So if there's certain nutrients, those kinds of things. But in terms of some of those other complications that we saw after we had the proton pump inhibitors for a long time, don't know for sure. Really, I can't speculate whether we're going to see those with this or not, or how the labeling is going to be worded relative to some of those other long-term, or whether this will have an indication for long-term use. Several gene therapies, just putting those out there. They're still in development and they're still moving along. These are some of the ones that are being reviewed by the FDA right now. So these are some of the conditions where we could potentially see in 2022, potentially into 2023, a decision by the FDA. The hemophilia ones keep getting kind of pushed out there as things arise, and the FDA wants to see longer data before they make a decision. So it could be that those don't get approved because they want the longer data. A whole bunch of oncology approvals. And unless you work in that area, you're not going to see the vast majority of these. So I'm just going to run through really quickly these, point out a couple of highlights. The radioligand was just approved, and that's targeting a PSMA positive. So it's a particular membrane target. And so it latches onto that basically, and then provides the radiation. So if people have that PSMA receptor type, then that could be useful. It's also $250,000 for a 6-week course. Lots of antibody chemo conjugate combinations. So again, also targeted therapies where that antibody is going after a particular type and then delivering. So in this case, a microtubule inhibitor, but there were several others. Lot more types that are directed at specific phenotypes. So doing the testing again, do they have this particular mutation, the KRAS G12C or those kinds of things. So it's for each of these kinds of cancers, and especially the non-small cell. We're seeing a lot more of that with testing. And all of these are pretty much being approved as 2nd or 3rd line therapy. For most of these are patients who have not responded to an initial course of therapy. But they got accelerated approval. Most of these are orphan drugs. Same here, lots of those. We had 3 more CAR T therapies approved. So keep in mind, CAR T therapies have REMS associated with the use, have to be prepared to treat that cytokine storm release syndrome. So patients have to be, inpatients, kept close by, in close contact, and you have to have that product available to treat them. So that's the REMS. More really targeted therapies, a couple more PD-1s. Oh, the second one there, that's an interesting Opdualag. It's a PD-1 blocker and a new LAG-3 blocking antibody, but they actually combine them into one product. So that's unusual for a combination. So nivolumab's already been available. They added in the second ingredient. It's a single injection with the 2 products combined. So that's unique in that sense. And then a whole lot of orphan drugs. So as I mentioned at the beginning, lots and lots and lots of orphan drugs. We saw stuff for chronic graft versus host disease, some specific vasculitis conditions, post-transplant CMV, and this is in patients who have not responded to other therapies, and they suggest phenotyping for resistance as well, because it doesn't work against all of them. So it's kind of a guided therapy there too. Another agent for myasthenia gravis, and this is if all of the other therapies pretty much have not worked. This is another alternative to eculizumab. Pegcetacoplan, which is also an alternative to eculizumabs for paroxysmal nocturnal hemoglobinuria. This is one of the only agents that also got approved with the REMS. So there's CAR T and then this therapy. Infection risk is super high with this, especially meningococcal. So making sure people are vaccinated prior to receiving that particular therapy. But again, it's a really limited indication and a really specialty population, as are everything here. Ropeg interferon for polycythemia vera. An alternative to hydroxyurea. Interferon's always been the alternative to hydroxyurea. This is just the first form that actually has the FDA approved indication and the clinical trials in that particular disease state, in the polycythemia vera. So it is otherwise just a long-acting interferon with all of the same interferon side effects and toxicities. And we've used the other interferons off-label for that indication for years when patients couldn't use hydroxyurea. Another Janus kinase inhibitor, some things that work on growth. The 2 other itch therapies that I mentioned, ileal bile acid transporter inhibitors. So these are really specific pruritus in intrahepatic cholestasis, which is actually a really severe itching condition that some cases, it's the primary symptom, but they actually end up having to have transplant because the itching is so severe. So this is a treatment for that, as well as another less common condition that you see down there. and some other deficiencies. And finally, a new approved treatment for African trypanosomiasis, sleeping sickness, which will not be used here in the United States, but expanded that indication and gave Sanofi the infectious disease credit to go on and develop some other medications, which is why they approved these kinds of drugs here in the US that won't be used there. And last question on Lecture Panda. So which of the following was not approved with a REMS? So yeah, aducanumab, which interestingly, Biogen submitted the product with a REMS. They were completely prepared to have it be available with a REMS because of that ARIA impact, and the FDA declined to approve it with the REMS and said a REMS was not necessary. So that is it. I know that was really rushed at the end there, and I apologize. If you want more information on any of those really orphan drugs or oncology drugs, I'd be happy to provide you some additional information. You can contact me, either my contact information at the beginning or here, pharmacy.druginfo@wsu.edu. We would love to have your questions. We have students and residents who are anxious to have your questions.
Thank you so much for that, as always, jam-packed wake up this morning. Thank you. So the code for Lecture Panda, thank you. Oh, and yeah. Dead. Oh, well, now it's working. Okay. The code for the CE today is Camellia. CAMELLIA. I'll add that to a slide.